All right, good evening. Thank you everyone for joining us this evening. My name is Ellen Henderson and I am the U.S. Professional Education Manager for NEUWAVE and HPB surgery. I'm going to share my screen so everyone bear with me as I do. I am going to start our event tonight. I want to welcome you all to this evening to the Mitigating Risk and Improving Outcomes. Sorry as I try to get into mode. And when we practice, this is the best thing about being on TV. So thank you so much. Like I said, my name is Ellen Henderson. I'm the U.S. Professional Education Manager, so I handle everything in the U.S. nationally. And we also have on the phone is Laura Spalla, who is our Regional Manager for Professional Education. And she handles all the events that would be handled regionally if you wanted to do one-on-one conferences, and especially with Dr. Liu after this. If you feel the need to have a conversation with him one-on-one on this or another topic, Laura would help arrange that. So everyone is on mute and their videos are off, but you have the option of putting in any questions into the chat box or the Q&A box. So, and there'll be sometimes during the event that Dr. Liu will ask some questions and you can enter the answers into the chat box. Sort of a little bit of a poll and kind of make sure everybody's awake, because I know this is very hard, especially at the end of the day for some of you. I did want to say to expect a follow-up email from me, and don't throw it into the trash yet or throw it into spam, but it will have some great resources after this evening on what NEUWAVE has to offer as far as professional education and upcoming events, as well as some different information that might be very helpful, as well as there's going to be a survey. And we really, really need your feedback, especially in these times where everything is on Zoom and gone virtually. Webinars become a bad word that you have to put almost $1 in the swear jar. So we want to find out ways that make sense in the times of day. So please be open and give us feedback on that, because that's something that's very important to us. So without further ado, I want to introduce Sandy Salerno, who is our VP of Sales and Marketing for NEUWAVE. And she is very excited about being here, but I'll let her talk about that.
Good evening, everyone. And yes, thank you all for coming to this program. I think it's going to be a very exciting and educational program for everyone. So please take advantage of it, participate, engage, put your questions in the chat box. Don't fear Dr. Liu. He's got all the answers and will help ensure that you have the information you need. So excited about us engaging. I also want to just acknowledge first our strong partnership with the Society of Interventional Radiology. It has been a great partnership with this society to really evolve our educational approach to this new dynamic world that we're in. And we're really excited to embark on this educational program tonight and also future programs that we have planned. So thank you again to SIR for their collaboration and partnership. And next, I really have the honor to really kind of present to our speakers tonight. As you know, Dr. David Liu. I'm sure a lot of you know his background, but I'll give a little bit more about who he is, and then we'll make sure we hand this over to him to kick off the program. So Dr. Liu is an interventional radiologist who is board certified both in Canada and in the US, and holds appointment at the Vancouver General Hospital and the BC Cancer Agency. Dr. Liu received his medical degree from the University of Toronto and completed his radiology residency at the University of British Columbia, and his interventional radiology fellowship at Northwestern Memorial Hospital in Chicago. In addition to his benchmark and clinical research in the field of novel embolic platforms and ablative technologies and career-related diseases, Dr. Liu maintains an active clinical interventional oncology practice that incorporates all aspects of ablation, embolization, venous access, and palliative therapies in many organ systems. He's delivered over 100 lectures worldwide and is an active member and inductive fellow of SIR. He has recently been awarded the CIRA Award from the Canadian Association of Interventional Radiology in recognition of his extraordinary contribution to the practice of IR in Canada and worldwide. And we're really honored to have him speak tonight. And we also appreciate all the contributions he is providing to advancing patient care. And that is so aligned to the ethicon vision of how we're shaping medical intervention and advancing care for patients. So this is a great program and partnership that we have, and we're honored again to have Dr. Liu here tonight. So I'd love to hand it over to him to kick off the program.
Great. So let me just get set up, make sure that everything is working. Audio is connected. Great. So I'm delighted to be here tonight with you, and certainly am in gratitude for SIR, Johnson & Johnson, the Johnson & Johnson Institute, and family of companies, as well as Ethicon NEUWAVE. A few years ago, when NEUWAVE had first entered into the ablation market, it seemed a little bit of an oddball entry because Ethicon traditionally or historically hadn't really spent a lot of time within the interventional circles. But through my relationship with the Johnson & Johnson interview, I can see and recognize that they're full tilt and committed towards moving interventional oncology forward. And certainly this event, as with many others, is really a manifestation of their commitment to interventional radiology. So I've been invited to speak tonight to you about a certain technique that has been developed over the years. It's basically been a partnership between the University of British Columbia and McGill University in Montreal. And we entitled this talk, Regional Anesthesia for Hepatic Ablation, Mitigating Risk and Improving Outcomes. And I hope in the next 35 minutes or so, we'll be able to introduce some of the aspects of this technique and also implement examples and use cases in order for you to see whether this might fit into your practice, especially in the times that we live in now with COVID and a real recognition of aerosol generating medical procedures, or AGMPs. This is especially appropriate for the ablation domain, and especially if you're doing CT guided ablations under general anesthesia. So these are my disclosures. It's a very wordy slide, but essentially what it states is that we're going to be talking about on-label indication, and that I'm being compensated for my time in preparing these slides and spending this time with you. As far as the indications go for the actual NEUWAVE Certus 140 system, it's as outlined here. It's basically indicated for partial or complete ablation of non-resectable tumors. We'll get into some of the nuances of the system later on, but this should at least level set our expectations. So as far as the outline of discussion, I've kind of broken it up into 5 areas. One, for many of you that are familiar with, is just a quick overview relating to the science of ablation. The second is really to identify some of the risks that we deal with on a day-to-day basis, especially in the CT scanner or in the angiography suite with respect to AGMPs, or aerosol generating medical procedures. I'll then introduce the concept of regional blocks from an anatomic physiologic standpoint, and then try to give you a practical approach to the regional blocks, and then give you some examples of what are the most commonly used regional blocks that we use on a day-to-day basis. Let's just kind of check the chat room. Let's just do a little bit of an icebreaker. So as far as the chat room goes, Ellen is going to be moderating, and if there are any questions come up, she's going to be interrupting me so that we can make this an interactive experience. So first question is, are you wearing pants, shorts, or pajamas right now? So if you wouldn't mind just kind of putting it in your chat room. I myself am actually wearing shorts along with a dress shirt. It's really hot here. So let's just see what everybody has to say.
Oh, we've gotten scrubs, we've gotten pants, shorts. Do scrubs count as pants or pajamas? So I think it's been scrubs, PJs.
Fantastic.
Sweatpants.
As a medical student, scrubs were PJs.
Yep.
So great. I think this is a real indication, first of all, that the AV is working, but secondly, that we have a really active audience. So once again, really like to make this interactive as much as possible. So if you have any questions, or if you want me to go back on slides, just put it in the chat box, and Ellen will flag me, and we'll explore in real time. So let's first give a very, very brief overview on the science of ablation. As we know, there are a number of different ablation platforms out there. Each of them has certain benefits, and each of them is based on a fundamentally different physical principle. So if we think about ablation modalities and thermal ablation, thermal can be both hot and cold. Of course, when we're talking about cold, we're talking about cryoablation. And with cryoablation, the magic number is minus 40 degrees Celsius. And minus 40 degrees Celsius, what happens is the biphospholipid membrane of the cell actually disrupts as a result of ice crystals forming. And secondary osmotic gradients actually cause the cell to flood in with electrolytes, which then also triggers apoptosis. So there's a primary and a secondary effect of cell necrosis. And this is kind of where you get all those fancy kind of 5-7-5 or 5-8-5 or 10-7-7-1-2, all these times of freezing and thawing. That's really designed to try and exploit the two different mechanisms in which cell death occurs or tumor death occurs from cryoablation. And then the other side is cell death via heating or by applying heat. And the magic number here is 60 degrees Celsius. At 60 degrees Celsius, proteins start denaturing, the biphospholipid membrane starts melting, and the cells are pretty much killed instantaneously. The secondary component of this is referred to as coagulative necrosis. And just as an interesting sidebar, although I'm jumping ahead a little bit, if you actually take a look at dead tissue under microwave versus radiofrequency ablation, they both look entirely identical. You can't tell it apart. So really what that tells us is it's really about hitting the target temperature effectively and for a sustained amount of time. That's really the most important in terms of the technology platform. There are, of course, other things that differentiate microwave from radiofrequency that we'll get into, but really it's about the kind of axiom of pathology. The issue is the tissue. We really want to get that target temperature, whether we're using cryoablation, microwave, or radiofrequency ablation. So microwave ablation kind of functions a little bit differently than radiofrequency ablation. This is just a very short video. I'm just going to, in the interest of time, just kind of jump ahead a little bit. Basically what it does is the microwave itself, sorry, I might have jumped ahead a little bit. Okay, the microwave itself actually causes rotation of water molecules, which then cause the frictional force, which then generates the heat. The most important part about this point is that it's actually not an electrical circuit, but it's actually the microwaves themselves that cause the agitation and heat. So therefore, we don't need grounding pads. And therefore, the wattage that we apply with microwave is completely different than the wattage we apply with radiofrequency ablation. For those of you that use microwave on a regular basis, as you know, typically we do 40 to 60 watts in a routine ablation with microwave. And for those of you that use radiofrequency, oftentimes we're going much higher depending on the product and the algorithm you use. You may be going up to 100 watts, 150 watts, etc. So if we flip over to radiofrequency ablation with an understanding that microwave ablation is about the actual radio waves causing water molecules to rotate, which then causes a frictional force, which then generates the heat, radiofrequency works a little bit differently. Radiofrequency ablation works on an alternating current. By definition, that means that you actually need the electrode and you need a grounding pad. And it's actually the electricity that flows between the two, the grounding pad and the ablation probe or electrode, that generates the heat. So the ions have to agitate. There has to be a transmission of current, which then generates the heat in the tissue. So this is a little bit different in that what we're actually talking about is using these electrolytes to exploit and taking advantage of the fact that the electrodes, whether it's multi-tined or not multi-tined, in other words, a single probe, the relative surface area of the electrodes is actually significantly greater, is actually significantly less, and we'll just use that as a squared as a illustration, is significantly less than the grounding pad itself. So the ions or electrolytes are actually agitating in uniform, and the electron flux or voltage gradient between the two is the exact same, but it's just that the surface area of the grounding pad is so much greater that the heat dissipates much quicker. So that means that it's actually subject to the person's body, general impedance, and the issue of roll-off becomes a concern, especially if we're heating too quickly. Basically, we mitigate or we destroy all the electrolytes by desiccating the tissue and thereby hitting roll-off, potentially without hitting our target temperatures.
Dr. Liu?
Yes.
We did get a question.
Sure.
It said, tissue looks identical after microwave and cryo. Why doesn't the dead tissue look completely dead after cryo as it does after microwave?
Sure. That's a really good question. There are two reasons for it. One is that when we do cryoablation, as many of you are aware, the actual architecture of the surrounding tissue, parenchyma, and interstitial tissue actually remains unchanged. So in other words, although we're destroying things on a cellular basis, we're causing microcrystals of ice to form, which then causes the cells to be destroyed. It doesn't actually alter tissue architecture. So oftentimes post-ablation, especially for post-cryoablation, especially if we're doing a solid organ like a kidney or a liver, morphologically, the tumor pretty much looks unchanged as compared once the ice ball thaws out. So the actual necrosis happens on a microscopic level. And oftentimes the secondary stress of the apoptosis from the osmotic gradients actually results in necrosis several hours, if not days after the insult, as opposed to microwave ablation and radiofrequency ablation, where we're actually creating direct thermal tissular destruction as opposed to secondary apoptosis. So the architecture of cryoablation post-procedurally looks unchanged. Meanwhile, with radiofrequency and microwave, as we mentioned, histopathologically and also grossly, when we look at it under post-ablation CT scans, looks contracted, fibrotic, looks scarred, or may potentially have some gas formation from the eschar from the ablation. Okay. So now that we understand the three different types of fundamentally different types of ablation, I'm not really going to get into IRE or irreversible electroporation because that's kind of out of the scope of our discussion. But certainly it is another ablation platform, as is external beam radiation, SBRT, as is Y90 or ablative radioembolization. But once again, I think that that's out of scope of what we're discussing because we're really going to be talking about nerve block techniques. That's really the primary focus of today's engagement and today's discussion. So as we know, there are high-risk AGMPs in interventional oncology, and AGMP means aerosol-generating medical procedures. And basically what these are procedures that can aerosolize in the room, aerosolize product, especially from the airway, in the room very quickly. Anything that requires general anesthesia, lung ablations, gastrostomy tube placement, cecostomy tubes and colonic stenting, duodenal stenting, NG tubes. And this really was something, this was kind of like the little secret that we had in interventional radiology, is that we were performing AGMPs in rooms and in procedure areas, which were not primarily designed to manage AGMPs. So anybody that does a intubation in a CT scan under general anesthesia is a perfect example. Do you actually know all the characteristics of the room that actually allow you to perform an AGMP safely? Do you know things like the room air exchange, whether there's negative pressure, if intubations are done in the room, are extubations as well? How long does it take for aerosols to settle in the room? It depends on the short answers depends on who's in the room, who's moving and who isn't, and how often are surfaces clean. I'm not sure if your interventional CT scanner looks like mine, but it basically kind of looks like a little bit of a storage room with a big CT in the middle because of all the equipment we use. And these were the things that we never really thought about or really didn't take a lot of consideration to until, of course, COVID hit. And I think that that has actually really focused our lens on best practices with respect to infection control. We do things better, we do things faster, we do things through smaller incisions and sites. Now what we have to do is make sure that we maintain the safety standards that have been established in the surgical suite, not only to protect our patients and our colleagues, but also to protect ourselves. So just for those, I mean, COVID is permeative. It's touched every single aspect of everyone's life. But I just wanted to give you kind of some simple facts to think about it and to consider. So a number of studies have suggested that if a person coughs, that the turbulent gas cloud of aerosolized particles can travel up to 26 feet in length. I'm not sure about you, but my CT scanner room isn't 26 feet. So that means that the droplets are not only dropping continuously, but they're also recirculating around in this small contained area for what can be potentially hours, depending on the room configuration. When we think about this in the context of AGMP, especially in the light of COVID, a number of different professional societies, interventional radiology professional societies, have provided us with guidance. This is the one that was provided by SIR, and just to identify here, the table that represents the AGMPs is outlined obviously in the link, and you can find this on the landing side of the SIR website. But basically, performing any AGMP that's likely to produce coughing, that's like an NG tube or intubation. Caring for patients who are at risk for mechanical dispersals of aerosols in the IR suite, So that's anybody who's dealing with stroke, or potentially those patients that are coming in from ICU. And during cardiopulmonary resuscitative efforts, so during CPR, we actually have protocols where we literally have to get out don and doff prior to entering into the code scenario that we've done multiple simulations on. So it's not just about PPE, it's about identification of risk and risk mitigation. Similarly, the Canadian Association of Interventional Radiology has a very similar kind of perspective on it, and this is more geared towards PPE. And then CIRSE and the APS-CVR has also demonstrated identified procedures that are considered AGMPs. But relevant to interventional oncology, I would say, and especially for the purposes of our discussion today, we are really going to focus on ablative procedures and specifically hepatic ablative procedures and how we can mitigate risk and at the same time improve outcomes and improve patient experience. This is really, in my opinion, a triple win, and I'm hoping that I can share with you not only these experiences but also reflect on them in your own practices as well. So we have risk stratification guidelines in our own hospital, I'm sure as you do as well. We have very specific roles in terms of intubation, extubation, air exchange, and cleaning and staff. And it's a very dynamic environment. The rules seem to be changing all the time, but really best practices as an operator, as a proceduralist, as an interventional oncologist should still be maintained. So that's where we really transition into this discussion relating to regional nerve blocks. Regional nerve blocks are commonly used by pain services and anesthesiologists. And in fact, many of you probably use them on a fairly regular basis for your spine and line room with ESIs, nerve root block, etc. Some of you may use hypogastric nerve blocks for uterine artery embolization. Obviously, we have experience with palliative pain procedures such as celiac nerve blocks and neurolysis. But also there are other procedures that you may or may not be familiar with, like hyperhidrosis with nerve blocks or Botox injections, Raynaud syndrome, complex regional pain syndromes, and rhizotomies. So this is not something new, but what's new, or what the innovation is really implementing this into hepatic intervention. So when we think about the lesions that we actually want to ablate, regardless of technology, there are lesions that are particularly challenging. There are lesions that are too big. Obviously, the application of microwave ablation technologies allows us to treat lesions larger and faster without needing multi-tines or extending or multiple electrodes, such as an RF, but also extending the borders of what we can actually effectively treat, upwards of 5 centimeters reliably. There are lesions that are too many. Multicentricity usually transition our hats from ablation to embolization. They're too close to critical structures. Once again, the intensity and speed in which microwave ablation can actually be applied helps mitigate the heat sump issues relating to the adjacent vascular structure, thereby altering, for those of you physics geeks out there, Penn's bioheat equation in favor of actual heat entrapment. There are those lesions that are not well defined, just means that you have to have a much bigger margin in order to be able to treat effectively. And of course, those nasty subcapsular lesions, especially up in segment 7, which are hard to localize and get to, and can be very painful because of not only phrenic irritation from just the muscular irritation, but also the subcapsular irritation of the liver, because that is innervated as well. And then, of course, what I call starburst lesions, which are lesions that had been ablated but demonstrate peripheral enhancement and recurrence, which basically makes the volume in which you have to ablate much larger than the original ablation volume. So these ones are quite nasty to deal with. So with that in mind, you can see that there are a number of situations where we have problematic lesions because we have to increase our intensity or intensify our treatment strategy. And as a result of that, oftentimes we have to approach these lesions and in general many other lesions with general anesthesia. But if you actually take a look at the liver itself, as we're familiar with in terms of its vascular compartments, it's divided into several segments, the classic Queen-R segmentation criteria. But what's even more important is the fact that if you actually take a look at the liver innervation, it's quite reproducible. The majority of the liver innervation actually follows through in a conduit based on the portal triad. So the innervation, the internal innervation of the liver, which includes the capsule as well as the visceral nerve endings, primarily kind of bottleneck through here. right around the confluence of the left and right portal veins. There are secondary contributors, splanchnic circulation, sometimes intercostals can come into play as a result of the adjacent peritoneal surface. Sometimes as I mentioned before, the phrenic nerve may come into play as a result of subcapsular, but by and large, the majority of liver-associated pain, not extrahepatic, but liver-associated pain can be mitigated if we can see and target this area. Now, we do portal interventions all the time, portal vein embolizations, as well as PTCs and biliary drainages. So this is not an extension. This is not a new skill set you need to learn. It's just identification and targeting a slightly different anatomical compartment. And the innovation for me actually came from SIR in 2016 when the McGill Group out of Montreal, Canada, headed by Louis Boucher, had really developed these periportal splanchnic blocks and had put a poster together. And this really kind of blew me away. And I can say now, fast forward 6 years later, that this is probably one of the most important innovations and adoptions that I've actually instituted in my liver ablation practice in years. And although microwave has markedly improved the scope and intensity in which I can treat, really these periportal blocks and these nerve root blocks allow me to do so with minimal anesthesia, minimal patient pain, and minimal complications. So if you're transitioning your practice towards these types of nerve blocks, what I'd recommend is to really start thinking about anesthesia and patient comfort as part of a continuum of 5 phases. So the first, because we're really kind of trying to design or level set your protocols so that the majority of patients can be treated under moderate sedation as opposed to intubation or general anesthesia in order to mitigate the risk of AGMPs being performed in the CT scanner. Really, that's kind of the mitigation of risk part of this talk. So in the first component, after informed consent, we really try to make patients as comfortable as possible. Stress patients require more moderate sedation. They require more benzodiazepines and more fentanyl. And of course, the risk that you have is putting these patients over and overdosing them and causing respiratory distress or respiratory suppression. So after consenting, I usually give a benzodiazepine. So in my case, I give Ativan 1 to 2 milligrams, diphenylhydramine or Benadryl, because that puts them actually at a little bit rest. And I make sure that I reassure them that everything's going to be okay. Something as simple as that really puts them at rest. I also make sure that they're well hydrated and prepared for the course of the procedure, because they're going to have a semi-lucid memory of the procedure itself. The second phase, which is probably the one that you're more familiar with, would be the sedation phase. So rather than intubating, we actually just use benzodiazepines and opioids, many of which you're familiar with. And we use smaller boluses because we find that this is just to get them comfortable. It's not really to keep them down. It's just to keep them comfortable. We then perform the nerve and regional block, of which I'll get into in a little bit more detail in a few moments. We then perform the ablation, and during the course of the ablation, we may just top up a little bit with very small amounts of IV bolus medication. So by very small, I mean 0.25 of Versed and 25 mics of fentanyl prior to the ablation, just so that they're kind of drifting down a little bit. And then, although during the course of the ablation itself, it's rare, we do top-up doses if the patient does seem to have some pain. And then post-ablation, this is actually the beauty of it. Once you perform the nerve block, especially if you use longer-acting local anesthetics like bupivacaine/Marcaine, these patients actually go home pain-free. So they actually go home routinely 2 hours post-recovery with just oral analgesics to be taken in on a PRN basis. And the heaviest or the most severe type of analgesic I give is a Tylenol 3. So this is also kind of addressing any issues or concerns that you may have relating to the well-recognized opioid crisis. So this is really the meat and potatoes of the talk. Here are the block techniques that we use on a fairly routine basis. I would say because this one has a little star on it, this is really my go-to. This is the one that I use 80 to 90% of the time. But really all we're talking about are anatomical access, using whatever modality you have to be able to get the anatomical access, and then the cocktail of injection. The parahilar one is really quite easy, and what I'll do is I'll highlight the parahilar, the celiac plexus, and also the hydrodissection, because I think that these ones are all kind of neat and relatively easy to do. You just kind of have to see it once in some case examples. But what you can see here is that the relative amount that's given is really small. In the case of the celiac plexus block, it's about 15 cc's of total volume. In a parahilar, it's also about 15 cc's of volume. And the only exception to this is doing hydrodissection. And essentially all this is just doing hydrodissection and adding a little bit of dilute lidocaine. The dilution does two things. One, it allows it to spread a little bit easier, and two, it also buffers the pH, because normal lidocaine in a fixed vial has a pH of about between 4 and 5, which is highly acidic. And if you dilute it, it won't bother that much. For those of you that do vein work, EVLT or RF, it's basically the tumescent anesthesia cocktail that we use for our hydrodissection protocols. And then there are, of course, some other kind of fancy schmancy ones that can occur on occasion you may have to use, especially if the tumor is infiltrative into the compartment. Intercostals and phrenics can be helpful. In intraarterial, when you're doing double hit therapy, all you really have to do is on the way out after your embolization and slowly infuse some dilute lidocaine. You don't want to infuse the lidocaine by itself because, as I mentioned before, it is of a low pH and it'll actually cause pretty profound spasm and can be painful. But if you dilute it with a little bit of normal saline, patients don't notice a thing. And basically the angiosome, or the anatomical segment that you dilute it into, becomes completely numb, at least from the liver capsule and inward. So a couple of rules to kind of keep in mind. Small and elegant is really the way we want to roll. And this is really what we do as interventional radiologists. 21 or 22 gauge spinal or Chiba needle in most cases. You want to be aware that, you may have not autonomic nervous system derangement. Frankly, I've never seen this before, but you do want to have these patients on monitor. And you also want to make sure that you confirm the compartment that you're in before the injection. You can use multiple imaging techniques. If it's near a vascular structure, you can ensure, you can aspirate to make sure there's no blood. In some places, in some compartments, you can actually use a little bit of epinephrine to see whether the patient's going to become immediately tachycardic. Personally, I don't like doing that because I think that it alters the vascular system. And you can also kind of add mix, especially in situations like tumescent and celiac, contrast injection to confirm that the compartment is completely saturated. And you could also use ultrasound with non-local anesthetics like saline and D5W in real time to make sure you're in the right compartment. You can use varying degrees and combinations of nerve block agents. You should, however, know how to reverse the individual agents. To be quite frank, the amount that you use is so small that the chance of overdosing is extremely small. But I think that you just need to have a fulsome understanding of the agents that you're using, especially when you're injecting them into compartments that you may not be familiar with. And then post-procedurally, you also want to obviously monitor these patients during their recovery to 1 to 2 hours prior to discharge. But as I mentioned before, many of these patients are pain-free when they go home, unless the peritoneal cavity or unless the skin or muscle has a little bit of soreness as the lidocaine wears off, but the liver itself is generally not an issue. So when I adopted into microwave, and specifically the NEUWAVE Certus 140, and I'm sure that once again experienced operators out there have noticed this as well, it hurts a lot more. It hurts a lot more than radiofrequency ablation in similar compartments, and it's perfectly understandable once you understand the technology platform. The microwave is very concentrated, right? So it heats up much faster, and the ablation zones are significantly larger for a single antenna. Furthermore, because it's so hot, it actually desiccates the tissue, and there are a number of very elegant studies that show this, where when you perform a microwave, the tissue actually contracts and eats itself back into the ablation zone, thereby increasing the actual ablation volume by about 30%. So to put it another way, if you have a 3 centimeter ablation at the end of your microwave, it actually probably represents about a 3.5 or 3.6 centimeter sphere of tissue that's contracted into the ablation zone. And this is something that doesn't happen with radiofrequency ablation because in radiofrequency ablation, you roll off before it becomes significantly desiccated. There are a number of features relating to the NEUWAVE microwave ablation system as compared to other microwave systems, but perhaps, Ellen, I might just take a pause here just to see if anybody has any comments or questions about the principles and physiology of these nerve root blocks.
Anybody has any questions or questions that they want to ask? We do have the Q&A in the chat box at the bottom of the screen. Dr. Lou, thank you so much already. I've been taking a ton of notes, so I appreciate it.
That's a pleasure. We're touching on quite a few topics, so hopefully we can bring it all together in the last little bit.
Yeah, and just to let you know, we have 42 people online listening, so this is a great attendance. So thank you to everybody again for getting on.
Excellent. 20 people in pants, 20 people in scrubs, and then I don't know what's happening with the other 3. So as I mentioned before, microwave can hurt more because of its intensity of ablation. And I think that's really why these nerve root blocks, especially if you're performing microwave, really make it much, much easier. As you know, with the NEUWAVE system, it's a 17 gauge probe. You know, the XT system actually has kind of a beefier base, so that's a little bit larger at its base, but the tip itself is 17 gauge. You can actually sync multiple antennae, which is something that you can't do with the other systems, and it has to do with the way that microwave actually syncs or could potentially cancel the radio waves. As you know, there are tissue-sparing patterns, and we'll talk about the probes in a minute. Power is significantly greater, especially with the LK and LN lines. We can, as I mentioned before, we can do multiple antennae with synchrony. So in other words, they can all go at the same time. The PDM, the power distribution module, is basically like the little satellite plug-in. And the engineering behind this, although it's out of the scope of our discussion, is actually pretty amazing. You can really tell that this system was designed by an interventional radiologist for an interventional radiologist, rather than having to shoehorn a technology into the angio suite and the CT scanner, because the PDM really makes a big difference. As you know, the microwave systems can actually cause a lot of feedback or backtalk on the antenna itself. And as a result of that, the probe itself can heat all the way back to the cabling. And there are different types of systems that can allow you for internal cooling. Some of these are a little bit of a pain in the butt to deal with, just because it's like corrugated tubing, or it kind of gets in the way. And the wire can still burn because they're really just trying to cool based on a piggyback cooling system. Meanwhile, with the NEUWAVE system, the CO2 pony tank, which is also used for tissue lock, actually actively cools the antenna to minimize the amount of heating through the tract and through the actual shaft of the antenna. So it's pretty cool. There's also software available, obviously, for tissue conformation, and there are a number of different types of strategies and treatments that can be done to really update and keep things in line that NEUWAVE actually does in the background with this call home feature. So if you ever have a problem, they can actually look at the entire ablation protocol, the devices you use remotely, in order to figure out exactly what's going on if there's a problem.
Dr. Lou, one question we got, and I believe that we're going to address this at the end, but I do want to confirm this. But
Sure.
I did get the question, if would this apply to renal at all, or is this a totally different algorithm? And I believe that's something that we had discussed in the beginning offline, but
That's a great question. Certainly the scope of this talk is really to talk about hepatic ablations. And we're actively looking, the innervation of the kidney is actually very well known. And we're actively kind of experimenting on some of the techniques as to how we can implement this. But I have to say at this point, I think that we're in a data collection phase and we're not ready to publish on the literature. But if you take a look at, if you crack open Netter, you'll find that the kidney itself does have an innervation pattern that's very similar to the liver, where all nerves go through a central distribution, which is basically the renal pedicle. The techniques, I have to admit, have not been refined yet, and unfortunately, I think it's out of the scope, out of the time that we have here. But certainly can explore those questions offline.
thank you.
So one of the things that you'll hear about is the actual frequency of the NEUWAVE system versus other systems. And the 2.45 gigahertz actually does make a difference because it actually allows for more reproducible and more precise burns. Think of it this way: if you have microwaves that are kind of at a lower frequency, spread wider apart, then the actual ablation zone itself becomes a little bit more ragged just because of the overlapping areas of radio waves. So it's not as reliable. But if you actually have kind of a very, very high frequency, like 2.45 gigahertz, it actually allows you much more reliable energy deposition within the targeted tissue. So that's really the innovation, is using this higher frequency application. And as I mentioned before, as compared to radiofrequency ablation, we don't get that kind of pattern of time to temperature. I'm using my mouse to draw this. That's why it looks like a 4-year-old is doing it. So if we take a look at time to temperature curve for a second, and we think about radiofrequency, what radiofrequency does is it does this, and then you drop off, and then it does this, and then you drop off, and that's really what signifies your roll off. But when you're doing a microwave ablation, what actually happens is your time to temperature curve does this, and it just flattens right out. And that's because the way that the power is being distributed as a function of the microwave itself, the 2.45 gigahertz, as opposed to radiofrequency, which runs usually on 60 hertz, which then peters out once the tissue becomes desiccated.
So one more, and another question that's come in, which is, I think, perfectly good time because of what you're getting ready to talk about. Would you comment on the spherical versus non-spherical shape of the burn? Is one question.
Yeah, so I think that there are two different aspects to that question. One is a microwave burn spherical? Well, the answer is yes. And two, how do you make a bigger sphere? And that's through probe synchrony. So maybe what I'll do is I'll just jump ahead to the next slide, to this slide first, and then I'll come back to the probe synchrony function. So NEUWAVE has two different types of, two series of probes, one which is kind of referred to as tip weighted, and one which is just kind of the standard. The standard is collectively the LK and the LN probes, and these really allow for much larger ablation zones. So these ablation zones can be 6 and 7 centimeters. There are actually 3 antennae built into them, and as opposed to the PR, which actually only has two small antennae built into the actual shaft of the probe itself, which then limits the amount of energy that can be deposited. But the reason why they did that in the PR is because there's a reflector up front, which actually causes the energy to reflect back, as illustrated here. So what that actually does is it makes it a little bit more spherical and also weighted towards the tip. So you don't have to kind of second guess where the ablation is going to go. It's going to start at the tip and work its way backwards, as opposed to the LK systems, which can apply much more wattage, so much more heat and larger ablation zones. But as you can see here, there's no reflector to kind of keep the heat from shooting forward. So those are the two geometries relating to the general categories. The PR being what's called tip weighted, and the LK-LN kind of being more of the sausage shaped configuration. And that actually brings up a really good polling question, Ellen, if you wouldn't mind. For those of you that use the Certus 140 NEUWAVE system, what's your go-to probe? Is it a PR, or is it an LK, is it an LN, is it an XT? Is it a 15 or a 20? Just if you just want to punch in your favorite probe, the one that you have the most of and use the most of.
PRXT. We got one answer.
Okay. Oh,
PRXT, PRXT.
Yeah.
PR.
Totally. Okay. So we're all on the same page here because I'm a big PRXT fan. The XT, for those of you that don't know, really kind of means that you have the, oh boy, okay, I'm going to try and do this with my crayon drawing. Really means that you have a beefier base relative to the antenna, and that allows you to steer a little bit better. So that's what the XT denotes. Of course, you have 15 and 20, so those are the two different lengths available. And the PR is tip weighted. So within the liver, the PRXT is my go-to. Now, the second question, which was which I kind of created out of that first question, is can you create a more spherical ablation? And the answer is yes. The easiest way to create a more spherical ablation that's larger than 3.5 centimeters or so is actually to use a synchrony function where you can actually put multiple antennae spaced apart, which then work together. They're like cheese and crackers. They're like peas and carrots. They work together to create a larger ablation zone. So they work better together than they do if you were just to do one ablation here, one ablation here, and one ablation here. So I hope that answered both aspects of the question. How to create a larger spherical ablation, which is using the synchrony mode. How do you create a rounder ablation? That's to use the tip-weighted PR individuals, plus minus XT with varying lengths. So as I mentioned before, this is the CO2 pony tanks, and you can see, like I said, you can tell there's an IR that designed it because you have two, you have a pony tank and you have a backup just in case things go haywire. You know, like nothing goes haywire in the IR suite. And basically what that does is it pumps in carbon dioxide. And carbon dioxide, when it expands, is referred to as endothermic. So in other words, it becomes cooler as it expands. And that really not only ensures that the probe itself doesn't get too hot, but it also does the tissue lock. The tissue lock, for those of you who do cryoablation, tissue lock is essentially like doing 20% cryo in order to have the probe kind of stick. For those of you that are kind of north of or around the Canadian border, it's kind of like when you stick your tongue on a flagpole in the middle of winter. That's essentially what the tissue lock is. Although in the prairies where I grew up in Manitoba, north of North Dakota, that was a sure way to that was the initiation for all the new kids that moved into town in the winter.
And one of the best scenes in Christmas Story.
So let's get in the meat and potatoes here. Let's get into some of these block techniques, and I have some examples to show you. So the 3 block techniques I'd like to illustrate in these examples are the perihilar block technique, which is basically periportal, the tumescent anesthesia technique, and also celiac blocks. You'd be surprised what you can get away with celiac blocks. So I'm going to show you kind of some what I think are pretty jaw-dropping images of what would be considered safe and acceptable approaches. So perihilar block technique, main thing, just to remind you that there are weight-based limits to treatment, whether you use ROPI, BUPI, or Lido. Here are kind of the limits, milligrams per kilograms. What I do in my technique is, once again, a tumescent technique. So I use 3 cc's of 1% lidocaine, plus minus epi. I've kind of fallen away from epi because I trust my hand-eye imaging localization. If I'm using CT, I'll use a little bit of contrast. If I'm using ultrasound, I'll inject in a little bit of D5W or normal saline instead of using the epi. I just don't like kind of uncontrolled administration of epi. And then add mixing that with 20 milligrams of bupi. Like I said, you can use ropivacaine, but I just use bupivacaine because it's handy. Bupivacaine is also known as Marcaine. And as I mentioned, I use contrast under CT or ultrasound confirmation of midline spillage. And I'll give you an example. So here's a patient, hepatitis C, basically normal LFTs, ablation was intended. Here you actually see the lesion itself. You can see it's right adjacent to the middle hepatic vein, nasty place for it to be, tumor sump issue, Penn's biothermal equation, bioheat equation that we talked about. Really going to be a difficult one to treat, and it's also oblong. 1.6 centimeters on the long axis. You can see right here, kind of, you can get a better sense of the anatomy. So, in this case, we pursued with microwave. Just out of curiosity, would anybody use radiofrequency or cryoablation in this area? Let's just see if anybody's awake, and just yes or no if you feel like it.
No, hell no. I love that. I got another no.
Okay.
Okay.
So we're all speaking the same language. There's going to be no debate about whether this is a microwave case. Difficult lesion, vascular sump, thermal sump issue, high recurrence rate with radiofrequency ablation. So here are just some screenshot images just under ultrasound. So as I mentioned, periportal, essentially splanchnic block, used a 22 gauge, 15 centimeter spinal under ultrasound guidance. So basically just anesthetized the skin, anesthetized the peritoneal surface, liver capsule, and just drove the needle down. Went right for it. You can see here the post-ablation 1 minute, really nice zone. You can see the snowstorm appearance on the outside, nice tract ablation here. Surprisingly, I thought that the middle hepatic vein might go kaput, but it actually was patent afterwards. At total medications, this is kind of the most amazing part of it, not the images, 50 mics of fentanyl, 0.5 of Versed. So that's like almost homeopathic doses of sedation, as many of you are aware of. I think when I do iliac stenting, I probably use 3 or 4 times more just because patients don't want to lay flat. So here's the post-ablation 1 month scan. So as I mentioned before, hepatic vein is still patent, beautiful ablation zone, well demarcated margins, and really this treatment was intended for a curative intent and was curative by nature. Just to go back on the profile itself, once again, pulling up my favorite and many of your favorites out there, PR15XT, forward weighted antenna. I did the 90 watt 1 minute surgical mode just to kind of get things started because I thought I was going to ablate and thrombose the hepatic vein as part of it, but that didn't work. Then just went on a standard 6 minute ablation with a tract ablation. So So really kind of tried to hang as much meat, so to speak, on that initial 90 watts or 1 minute surgical mode. Here's a companion case, kind of a nicer picture. You can see here's a 21 gauge Chiba. You can see here's the portal vein demarcated by the increased echogenicity of the periportal fat, of many of which are familiar with. Here's just the image of the CT scan, just correlating, showing that the perihilar kind of fat area is really where you're going to be targeting for. I'm just going to just drop out of my pen for a second just so I can do this. Okay, so here what we see here is kind of a second companion case, and what you see is the needle in place, and you can see the actual injection. This is actually just a little bit of loculation. So I just thought, nobody's going to believe me unless proof is in the pudding. So I'm going to mix a little bit of contrast in here and do a cone beam CT. So here you can see the cone beam CT beautifully delineating where the contrast and subsequently the local anesthetic is distributing around the portal vein. I think the coronal is very convincing along that spot, bathing the entire nervous pedicle going into the liver. And in this case, we actually were able to do this block with no sedation and local only. The patient had a very, bad cardiovascular history. Anesthesiologist was on standby, but essentially we did this with local anesthetic only, and it was a relatively straightforward ablation. Once again, PR15 XT, and this was just going to be a 6 minute 45 watt ablation, which is kind of our standard ablation profile. Any questions on that, on the perihilar block technique?
I did get one. I want to make sure that we answered it correctly. Within your, since you use deep local sedation injections and lidocaine as sedation methods, does this mitigate any pain release after a liver ablation?
Absolutely. Yeah, definitely. It actually does, because the admixture of the marcaine or bupivacaine gives them up to 24 to 48 hours afterwards of relief. So many patients, they may have some muscular pain as a result of, going intercostal or going through the abdominal muscles. But generally speaking, they don't have that deep pain that can be associated with nausea and significant discomfort post-procedurally. So that's the added benefit. The win for us is we don't have to use AGMP. The win for the procedure is that we don't have to use sedation, so the anatomy doesn't change a lot. And then the win for the patient is that they actually have substantial improvement in their post-procedural pain management without the requirement for opioids.
Okay, and two more. You got two more. So we've been asked to talk about the learning curve for doing a peripheral block, and then also looks like some air injected, or was that post-ablation? So
yeah, this is post-ablation, so that's just the gas formation there. Sometimes, as you know, when you put a needle in there, you get a little bit of air in the needle shaft, so that can happen, and it's nice and illustrative for the purposes of our discussion. As far as the learning curve, if you do a PVE or you do a PTC, like how many times, seriously, how many times do you guys hit the portal vein when you're trying to do a PTC? And how many times do you hit the biliary system, or find it really, really difficult to get in the portal system when you're trying to do a PVE? So it's just basically the same thing. It's the same kind of technique as essentially doing a PTC, only in this case, you're trying to go for the central area. And if you do spine work or long needle work, it's very, very easy to do. There's not really a big learning curve to it. The only thing is just making sure that you have in your mind the correct order, and put this technique in the context of a sedation kind of story arc of pre-procedural minimization of stress and anxiety, intraprocedural, just kind of dab them with a little bit of IV sedation, keep them comfortable, then performing the nerve block, performing the ablation with a little bit of top up, and then just monitoring afterwards. So that's really the most important part, is that it's not just the procedure. You kind of have to mentally level set yourself to be able to manage an awake patient in the room.
And then one more question. So this is great. It's targeted at extrahepatic PV, correct?
Yes, correct. So you can actually target segments. So just to kind of go back to here, if you're doing a lobar, sometimes, especially with larger patients, it's kind of hard to see the main portal vein. But essentially, you can see here, in this case, I'm in a sagittal plane, and I'm probably hitting more towards the confluence of the right portal vein. I think that this image really illustrates it well. You just need to. This is horseshoes. This is horseshoes and hand grenades. This is not precision, precision localization, because you're really talking about dispersal of the local anesthetic. It's kind of like doing an epidural steroid injection. Some patients will say, "Oh, I needed an L3, L4, L4, L5," when really you know that it disperses up and down. And ultimately, that's what this really represents. We don't really need to be super precise. But that being said, sometimes when you have a larger patient or a patient that's non-compliant with breathing or has a belly full of gas, you can do the right portal vein or the left portal vein under targeting in a very similar fashion and get the same type of relief. Okay. So let's go on to the next one. This one probably many of you are familiar with. This is celiac block technique for pancreatic cancer or chronic pancreatitis. We do this as neurolysis, usually under general anesthesia with alcohol. In this case, we're just using those same technique, commandeering them for the purposes of performing an ablation. And just as a sidebar, these techniques can also be used for PTCs and also for PVEs. So for those of you who need to do percutaneous bile tube placements, or those of you that do PVEs, this can actually be used fairly effectively. Whether they're indicated or not, that's kind of up to you, but certainly can be applied. So just a reminder, once again, use your be aware constantly of your maximum weight-based dose limitations. So to give you an idea, lidocaine, depending on who you ask, is somewhere between 5 milligrams to 10 milligrams. So the average 70 kilogram adult male will actually require a stupid amount of lidocaine, more than you could ever inject in the compartment. So that's why I say you generally don't have to worry about it, but you just have to be aware. Administration technique, very similar to the periportal, a little bit of lidocaine plus minus epi. As I mentioned, I use contrast and saline nowadays. The bupivacaine, 15 cc, so a little bit more, and that's for the post-procedural relief. I will warn you, though, that the celiac block technique does not necessarily take out some of the splanchnic variants that occur as a result of parasympathetic chain. So that means that if you're doing an ablation after doing the celiac block, patients may actually present with nausea because of the sympathetic overdrive and potentially kind of a vague, deep pain that they can't localize. So that's something that you want to be aware of. I think the parahilar block technique is much better because it's truly the bottleneck, but the celiac block technique can be used with good effect to decrease the amount of sedation you need. So classic is CT-guided posterior approach along the crest of the diaphragm, riding along, try not to hit big red, the aorta right here, injecting a little bit of contrast, confirming. You can use 2 to get that horseshoe configuration, and then you can inject in your local anesthetic. You can do some crazier things if you're using a 21 or 22 gauge needle. Here's a transaortic approach, single needle approach. So you can do the transaortic approaches are very well established in the literature, and it's a very easy way to be able to get into that compartment and use a single needle midline technique. You can also here's the zany one. So you can go transhepatic. You can also go transgastric. You can also go pancreatic, to be quite frank, with these small needles and be able to localize into that same compartment. So really celiac axis, CT guidance, localizing. If you have a really skinny patient, occasionally I do this, you can pull up a 5 centimeter or a 3.5 inch 21 gauge spinal and do it under direct ultrasound guidance to very good effect. So with these celiac blocks, let's just kind of pause there for a second. Ellen, do we have any questions or any comments?
We do have one. How do you determine 45 watt for 66 minutes versus 65 watts for 10 minutes with a PRX XTR probe? Excuse me, goodness.
Yeah, I think that there are different flavors to the ablation itself. As I mentioned to you before, as long as you don't kind of think of the wattage in microwave as the same as the wattage in radio frequency, then you may or may not have to go from 40 to 65. Frankly, most of the times I use 45 to start. I'll use that surgical mode, 90 watt 1 minute, just to kind of mobilize the tissue or just kind of see where my potential ablation zone is. And what I'll end up doing is if I find that I'm not really getting the margins that I want to, that I'll then go up to 60 for just a short period afterwards. Bear in mind, and this is something that really kind of changed my understanding of ablation profiles with microwave ablation, that the retraction itself even at 45 watts, is pretty profound. The tissue desiccates and sucks into the area where the microwaves are actually generating heat. So even though you may kind of think that you're only getting a 3 centimeter lesion, and I'll show you some examples in a moment, you're actually going to be getting substantially more. So I don't think that there's any fault in doing a 60 watt. I think that it's kind of more just a flavor and a preference. And certainly, certainly some of my practice partners prefer to do a 60 watt ablation just to get a bigger zone definition. If I think I need to go to 60, oftentimes I'll kind of think about going to an LK, because that means the lesion is quite large, and I really want to be able to define or select my antenna based on the long axis. The long axis of the lesion defines what in my opinion, defines the probe and the ablation profile that you use.
All right.
Okay, great. So last is tumescent anesthesia. This one's just silly easy. So just to remind you, weight-based limitations, and essentially, as I mentioned, for those of you that do EVLT or RF for saphenous veins, it's basically the same thing. All you have to do is just dilute the lidocaine. So I use 1 mil and 10 milligrams of normal saline. I dilute it 10 cc's in 250 cc's or D5W. You can use contrast or not, and don't use epinephrine. That's one actually really important thing, because epinephrine spilling into the peritoneal cavity is not only quite painful, but also can cause a significant amount of spasm within the GI tract. So here's a patient, 72-year-old male, colorectal carcinoma, primary ablation strategy. He had 3 ablation sessions over 2 years, elevated CEA, a Child's P score, and a good performance status. So kind of a nasty lesion you can see here. It's actually a recurrence. So that's that starburst configuration. It's oblong. And as I mentioned before, you really want to define the ablation by the long axis of the approach. And in this case, on the paracoronal or sagittals, you can see that the long axis is this dumbbell configuration here. So really a difficult lesion to treat for 2 reasons. 1, colon is here. 2, peritoneal surface is here. And 3, there are 2 liver capsules that you're actually going to be ablating. So that means it could potentially hurt twice as much. This is really kind of one of those anatomical difficult areas. You don't want to burn the colon. You know it's going to hurt like hurt like nobody's business because of the 3 innervated areas here, and also it's oblong. It's oblong in a starburst type lesion. So you have to have an ablation zone that's larger than what you see here, substantially larger. So tumescent anesthesia technique, I don't really want to go into a hydrodissection technique, but that's essentially what you do. What I usually do is I just use a 4 French UE or a synthesis type kit, and then just do overselect and then do a loss of resistance technique under ultrasound guidance till I see it splitting into the peritoneal cavity. Then I deploy the catheter and then just start injecting. Much like any tumescent anesthesia that you do. And what that does is it actually completely numbs up the liver capsule. So just to give you kind of some indication of where we are, just to orient. So here we have the liver capsule. You can see kind of a little bit of, I think it's bile duct or portal vein here. You can see the superficial tissues here. You can see the muscle. You can see the ablation probe here. It's an LN probe. And what you're going to see is, in a moment, is me massaging the tissue during the ablation in order to milk the tumescent anesthesia into the ablation zone. So this is kind of in slow motion. What you see right there is the separation of the liver capsule from the peritoneal surface. And I'm actually milking the local anesthetic into the lesion because the microwave is so profound in its ablation, it basically carbonizes the tissue around the ablation probe, so you can kind of move it around a little bit. Now, as I mentioned before, with the ablation zones, they're much larger with microwave because of the tissue retraction. And I figure I'd just kind of give you an apples and oranges comparison, because you can see here in the latter phases of the ablation, you can kind of see how much the tissue has actually become corrugated and retracted down to its surface. It's pretty substantial as compared to the pre. And that's one of the reasons why I have a tendency just to stick with a 45 watt. Not that there's any fault in the 60, but the 45 watt seems to do me fine with the PR and the PRXT. So just a little reminder, although you can kind of see me, you can see the antenna moving in and out, milking that tumescent in place. Don't do that until a couple of seconds into the actual ablation profile, because as many of you know, the tissue lock function is actually just kind of forming an ice, your tongue on a flagpole in the middle of winter. And when you transition into microwave, what happens is that ice melts for a few seconds, and that's when the probe is actually completely mobile. So until you're in 30 seconds in or so, when the tissue is charred around the actual probe itself, you really want to be careful about over manipulating and going hog wild on milking the tumescent anesthesia inwards.
We do have a question.
Sure.
Does this sedation technique create a heat sink within the ablation zone?
No, actually, it doesn't create a heat sink in the ablation zone, because just to kind of further to this, let me just show you. Okay, what it actually does is you're just kind of milking fluid in and out, and you know the capsule is going to be burned dead. And here's just kind of another example. This is kind of the final ablation, just showing the tissue retraction. So you can see the divot that's happening. That's actually the tissue retraction being demonstrated. And what you can actually see is the cold and hot tumescent anesthesia milking in and out in this video. I slowed it down a little bit so you can see better. So just to kind of reiterate, you can see the little divot in the tissue here. You can see the tumescent anesthesia milking in and out. And I think that actually causes a heat sump to benefit, because then you're not irritating the peritoneal surface, you're actually facilitating internal cooling. But, you know, quite frankly, this stuff is just gone. This is all an eschar. It's just a full scar. And here you can see the degree of retraction that happens at the completion of the ablation profile.
Oh, we have another question. Does it work together with artificial ascites?
Yeah, so basically artificial ascites or hydrodissection is essentially this technique. You're just mixing a little bit of lidocaine into it. So yes, if you do hydrodissection, if you do artificial ascites, this is right in your camp. And the other kind of part of artificial ascites is, as some of you probably are concerned, when we do artificial ascites with radiofrequency ablation or with cryoablation after it thaws, with radiofrequency during the course of the procedure, there is a potential for hemoperitoneum and peritoneal bleeding. But with microwave, it's so darn hot that it actually creates an evacuated eschar, and you'll see that in a moment. So here's our final. So just to kind of give you the profile is an LK probe, location of lesion with this type of ablation, and we hit a target temperature. So our final shot is this, and I think that this is kind of going to demonstrate a very efficacious kind of ablation. So what we can see here is extensive, obviously profound ablation in that bilobe configuration, and it had minimal bleeding and a dissipation of the hydrodissection. The ablation zone extended end to end, as you can clearly see, and did not involve the colon, which is obviously good for us. But more importantly, the patient was able to be done under moderate sedation without much issue or problem. So what you can actually see here, in that little black kind of blob, I'm sorry, trying to get it right. Apologize for this. What you see is a little black blob in the middle, and that's actually the scar eschar. I've been fortunate enough to be able to look at some of these ablation zones in porcine models where we actually do the resection immediately, and that literally is just like a hollow cylinder right down the middle. Because the ablation is so profound and the tissue is completely dry, so it cauterizes the tissue on the way out. So to kind of come back to the artificial ascites and tumescent anesthesia and hydrodissection techniques, I have no problems leaving the fluid behind, and I have no problems or concerns about causing hemoperitoneum post-ablation when using the NEUWAVE system.
You did get another question. And when do you get worried when you see post-ablation contrast extravasation?
Honestly, I have not seen we do CT scans, we do triphasic CT scans immediately after our ablation. So we'll just kind of set that up to be able to look for our immediate prognostication of our result, but also to look for extravasation, because I have seen that before. If any of you guys do kidney or any folks do kidney and cryo, you've seen that pumper come out afterwards and it just makes your heart sink. With microwave, I have not seen any substantial bleeding, and certainly haven't done any post-procedural embolizations. So I can't really answer that question because I've never actually seen it with the NEUWAVE system. So I hope, I know we've gone a little bit over time, and I'm certainly grateful for the time, the questions, and the opportunity. And I'm just going to wrap it up with this, this following slide, because it really kind of is a touch point for all the reasons why I think these nerve block techniques should be implemented. Well, first of all, it's easy and it's free. It really decreases the amount of hospital resources that are required, especially with respect to anesthesia. And depending on your region, you may actually be able to bill for a regional nerve block, very similar to hypogastric nerve blocks when you do urinary embolization. It truly does improve pre, intra, and post-procedural comfort, because now all of a sudden I'm starting to see it from the perspective of the patient experience, from the lens of the patient. And I think using these types of blocks really gives them a much more comfortable experience. It allows for fast recovery and discharge, especially if you have more aggressive ablations, because it decreases the complications associated with overdose of sedation. You know, my main concern in the beginning before starting to use using microwave is that I had to give more and more sedation to the point where all of a sudden, you know, the flumazenil and the Narcan come out, and then you're in a whole nother world of complicated management. But these nerve root blocks have decreased the amount of sedation that we need substantially. As I mentioned before, the decreased risk of AGMP is really substantial. Although this was kind of a minor concern before the COVID era, I think that this is actually probably one of the most important reasons why these nerve block techniques should be implemented. And it also improves overall procedural room efficiency. There's a lot less futzing around with anesthesia carts, intubation, extubation, and kind of all the other equipment. You know, we all have enough equipment in every room, and if we can reduce our footprint by a little bit, that just allows us to mobilize a little bit more. And although I didn't really get into it, but I did allude to it in that last case, these types of blocks actually allow us to increase our treatment intensity. We can treat larger lesions. We can use this, you know, the synchrony mode to be able to create larger round lesions. We can increase our wattage without much concern. We can do capsule to capsule. We can also do other types of adjunctive techniques that, such as ablation and embolization in the same sessions, using longer sessions. Without concern about over-sedating these patients, especially if you're not planning on using general anesthesia. So I didn't get into it, but double hits therapy, where we do an embolization and ablation. We also use these nerve block techniques, and we also use intra-arterial infusion of local anesthetic, as I had mentioned earlier. So once again, I'd really like to thank SIR for this platform to be able to spend this time with you. I'd like to thank the Johnson & Johnson Institute, Ethicon, and NEUWAVE for their support of this initiative. And I certainly would like to thank all of you for sticking it through the extra 14 minutes in this session. And
well, you do have one more question too, so I can't let you go quite yet.
I can't.
One last question is, if hydrodissection more than 500 milliliters, do you multiple the dosage?
Yes. Yeah. So it's a proportional dilutional ratio, not an absolute amount of lidocaine. Very similar to when we use tumescent anesthesia for vein work. So yes, you do need kind of a certain level. And as I mentioned before, 500 cc's based on the amount of lidocaine that you may be using, or bupivacaine for that matter, is still based on that dilutional ratio, is still well under what would be considered the systemic toxicity dose for a patient.
All right. Well, if there's no further questions, I want to thank you so much, Dr. Liu, on behalf of J&J Institute and NEUWAVE. And again, thank you for our partnership with SIR. Everyone have a wonderful evening, and please let us know if there's anything that we can do to further your education. Thank you.
Thank you.